Okay, a very welcome to all of my dear viewers. So in today's session we are going to discuss a very important topics of medicine, and also it comes under the community medicines, and the name of topic is acute rheumatic fever. Okay, so first we try to understand what is the meaning of this acute rheumatic fever. So what happen whenever any person is suffer from Group A beta hemolytic streptococcus infection. What I am telling to you, whenever any person is suffer from Group A beta hemolytic streptococcus infection that mostly cause the pharyngitis. So after 2 to 4 weeks of this infection, there is autoimmune reaction develops in the body. So this autoimmune reaction start damaging the body own tissue, especially they target to the heart tissue, joints tissue, subcutaneous tissue, basal ganglia and the skin tissue. So these 5 or 6 are the commonly tissue which is affected due to the cross reaction of autoimmune cells. So what happens due to this cross immune reaction, there is auto-inflammatory response is generated in our bodies, and this autoimmune inflammatory response which is generated due to the cross reaction of antibody with body own cells, it is called acute rheumatic fever. So again I am going to repeat what I am telling to you. First, any person is suffer from beta hemolytic streptococcus infection, and after 2 to 4 weeks of this beta hemolytic streptococcus infection, there is cross reaction of immune cells with body own tissue. So now the question is arise, why there is the cross reaction of antibodies with body own cells will occurs. This is because the organism which is beta hemolytic streptococcus, they present specific proteins, and the name of protein is M proteins, and this M protein is analogous to our body own proteins which are mostly present in heart, skin, subcutaneous tissues, basal ganglia and the joint especially the synovial membranes. So due to the analogous nature of M protein with a body own tissue, there is cross reaction of antibody with those tissue, and due to this cross reaction there is the auto-inflammatory response is generated, and we call it as a acute rheumatic fever. Okay, so this is all over about the definition of acute rheumatic fevers. So now after the discussion of acute rheumatic fevers, we move towards the clinical features. So in clinical features, the most common feature is the patient is present with fever and a joint pain. So this joint pain may be inflammatory, or in some case it may be non-inflammatory. So if the joint pain is inflammatory, we call it as a arthritis, and if joint pain is non-inflammatory, we call it as a arthralgia. So what is the difference between this arthritis and arthralgia? Arthralgia is a non-inflammatory response. Here the patient they tells he or she having only joint pain but no any sign of inflammation. But in case of arthritis, patient present with sign of pain along with the sign of inflammation. So if any patient present with pain with sign of inflammation, we call it as a arthritis, and if patient present with only a joint pain, we call it as a simply arthralgia. So now the next point is that this joint pain may be migratory or polyarthritis, polyarthralgia, or monoarthralgia may be migratory or non-migratory. So patient present with either they having a migratory polyarthritis or polyarthralgia, or they having a non-migratory polyarthritis or polyarthralgia. So if any patient is present with migratory polyarthritis or migratory polyarthralgia, then it is most evidence, or we can say that it is hallmarks of the acute rheumatic fevers. But in case of monoarthritis or monoarthralgia, it is not more evidence to say that patient having acute rheumatic fevers. So this is all about the joints. So now the next clinical feature is the carditis, and this carditis is the only feature they having a long term complication among all the 4-5 clinical features that I am going to discuss, that all are at transients. After some times a patient will recover from this and they having no any long term complication. But this carditis, they having a long term complication due to the involvements of valve of hearts. So what happen in case of the carditis? Carditis means inflammation of the hearts. It may involve the outer layer called pericardia, and we call its condition as a pericarditis. If myocardium is involved, we call it as a myocarditis. If endocardiums are involved, we call it as a endocarditis. And when all the 3 layers are involved, we call it as a pancarditis. So what happens in carditis? Mostly it affects the endocardium tissue, and in endocardium tissue they mostly affect the endocardium of the valves, and in valves mostly they affect the mitral valves. So what I am telling to you, in case of carditis or in case of the acute rheumatic fevers, the common valves which is affected is the mitral valves, and in some case it also observed that there is the involvement of aortic valves, but the most common valves affected during this acute rheumatic fever is the mitral valves. So what happens? Due to the erosion of the leaflets of mitral valves, there is the fibrosis, and there is the platelets deposition. So due to the calcium, platelets and the fibrous deposition, the leaflets of the valves, they become sticky in nature. So when the leaflets of valves it become sticky, now it is difficult to her to open the valves to eject the volumes. So now here what happens, due to the sticky nature of the leaflets of mitral valves, they increase the afterload, or we can say that they increase the resistance to eject out the blood. So it is a common complication seen in case of the mitral valves involvements, or in a case of acute rheumatic fevers. But what happens when there is a recurrent infection of this streptococcus, group A beta hemolytic streptococcus infection will occur. So that leads to the fibrosis of valves, and if there is the fibrosis of valves, it causes mitral stenosis. So mitral stenosis is not a feature of acute rheumatic fever, it is a feature of rheumatic heart disease. Or what is this rheumatic heart disease? Rheumatic heart disease is due to the recurrent infection of the streptococcus, beta hemolytic streptococcus, or we can also say that it is the recurrent acute rheumatic fevers. So when there is the recurrence of acute rheumatic fever will occur, they damage more the valves, and if there is the more extent of valve damage, that leads to the fibrosis in valves, and they narrow the openings or narrow the valvelets openings. So if the valvelets opening is narrow, it will cause mitral stenosis. So this mitral stenosis is not a feature of acute rheumatic fever, it is a feature of rheumatic heart disease. So what happens in case of the acute rheumatic fever? In acute rheumatic fever, there is only the leaflets of the mitral valves, they become sticky. So when the leaflets of the mitral valves they become sticky, they resist the ejection of blood from the left ventricles. So if there is the resistance in ejection of the blood due to the sticky natures, somehow it can no, they slightly reduce the stroke volume or cardiac volumes, but there is no any matlab what they not affect the cardiac output at a high extents or the high levels. But the problems that face is that due to the sticky natures or the platelets aggregation, here what happens, the valves are one thing that the valves are not open properly due to the sticky nature. The another thing is that the valves are also not closed properly. So if the valves are not closed properly, that leads to cause mitral regurgitation. So this mitral regurgitation is one of the complication of we can say that acute rheumatic fevers. So what are the more things which comes under this carditis? One of the common things is the first there is the valvelets, they become sticky, which increase the resistance, and it will cause a mitral regurgitation. Sometimes it also affect the aortic valves. So if they also affect the aortic valves, it cause a aortic regurgitation. So now the question is arise, how can we identify a patient having a aortic regurgitation or the mitral regurgitation? So for the mitral regurgitation, the clinical sign is that we check pain systolic murmurs. So if any patient having a pain systolic murmur, it indicates the mitral regurgitation. And if any patient having a early diastolic murmur, it indicates the what aortic regurgitation. So if any on the clinically if you observe that a patient having what pan systolic murmur, it is suggestive of mitral regurgitation. And if a patient having aortic regurgitation, it is identified with the help of early diastolic murmur. So these two murmurs is the clinical sign. On this basis we can identify a patient having a aortic regurgitation or the mitral regurgitation. The another things what we do, we can also go for the echocardiography. On the echocardiography, it is more evidence that patient having aortic regurgitation or the nodes. So with the help of echocardiography and the clinical sign, we can find that a patient having a mitral regurgitation or the node. One more things will happen in case of this acute rheumatic fever is that they also involve the conduction system. So when they involve the conduction systems, basically they involve the AV node blocks. So due to the AV node blocks, there is the increase the PR intervals, which we find with the help of ECG. So if in the ECG paper we find that there is the increasement of the PR intervals, which indicates that patient having a AV blocks due to the acute rheumatic fevers. So these all things about the carditis. Now the next thing is that chorea, especially Sydenham chorea. So what how this chorea will happen? This chorea will happen because the immune cell or the antibodies, they cross react with the neuronal circuits of the basal ganglia. So when this antibodies or we can say that immune cell, they cross react with the neuronal circuit of the basal ganglia, which is a main role for controlling the all the movement or all the programs or all the voluntary or involuntary program which they proceed by the they process by the basal ganglia. So if there is the damaging in a circuit of the basal ganglia, that leads to cause involuntary purposeless movements, and this involuntary purposeless movement we call it as a Sydenham chorea. So this Sydenham chorea is due to the damaging at the level of basal ganglia. What are the other features? The other feature is there is the formation of subcutaneous nodules, and this subcutaneous nodules is the painless and present to the extensor surface of the joints. Next clinical manifestation at the level of a skin, and what is the clinical manifestation? The formation of erythema marginatum or the hypopigmented lesion. So this erythema marginatum or the hypopigmented lesion is due to the involvement at the level of skin. So this all are the clinical features of the acute rheumatic fever. Now we move toward the reading section what I am right here. So we start with the definition acute rheumatic fevers. What is it? Is the autoimmune inflammatory disorders that occurs after 2 to 4 weeks. Group A beta hemolytic streptococcus infection, and this is because the M protein of the streptococcus bacteria analogous to the heart, joints, subcutaneous tissue, basal ganglia and the skin. So these are the site where the immune cells cross react with the body cells, and so antibodies after the post streptococcus infection, they cross react with this tissue, leads to cause inflammation in this tissue, and when the recurrence of the acute rheumatic fevers, that leads to cause valve damage and especially the mitral valves and condition called rheumatic heart disease. So what are the things written here? It tells that after the acute rheumatic, it tells that after the 2 to 4 weeks of the group A beta hemolytic infection, there is the formation of antibodies, and these antibodies cross react with the skin tissue, heart tissue, joints and the basal ganglia, subcutaneous tissue. So these are the tissue where the immune cell react and produce the clinical manifestation, and when there is the recurrence will occur, we call it as a rheumatic heart disease. Okay, so what are the clinical feature? Patient present with the fever with the joint pains, and joint pains may be arthralgia, polyarthralgia, monoarthralgia, polyarthritis, migratory, non-migratory, like that. Carditis involves either all the 3 layers. We call it as pancarditis, or it may be single layer. Mostly they affect the endocarditis. So what happens? Endocarditis are the mostly involved that cause the fusion of the margin of leaflets. So why this fusion will occur? Due to the sticky nature, which increase resistance for opening of the valves, especially the mitral valves. Due to the improper closing of the leaflets, it also causes the mitral regurgitation, and in some patients along with the mitral regurgitation, they also suffer from the aortic regurgitation, already discussed. Clinically, mitral regurgitation is identified by the pansystolic murmur. How we can identify the mitral regurgitation? Mitral regurgitation is identified with the help of pansystolic murmur, and the aortic regurgitation is identified by early diastolic murmur. So these two are the clinical signs. Mitral regurgitation by the pansystolic murmur, and the aortic regurgitation by the early diastolic murmur. Okay. So where we identify the mitral regurgitation, I mean pansystolic murmur is identified at the level of apex, and the early diastolic murmur identified at the level of aortic area. Okay. So when recurrence attacks will occur, that leads to the fibrosis of leaflets, and they increase the more resistance, higher resistance, that cause the heart failure. Obviously, when there is the higher resistance, I mean afterload will be increased. So there is more energy generated, or the pressure generated by the ventricles to pump the bloods, and with at the end stage it may be cause the heart failures. Conduction system is also affected, which is indicated by the prolonged PR interval. Arthritis may be migratory polyarthritis, already discussed. Sydenham chorea, erythema marginatum, and erythema marginatum, redness at the margins and central pallor. What happens? There is the redness at the margin and the center pallor, and this lesion are non-painless, non-pruritus, I mean non-itching in nature. Then there is the subcutaneous nodules. They correlates with the severe carditis. Okay, so what that tells, if any patient is present with the subcutaneous nodules, we think that a patient may having there is the carditis or involvements of the valves. Nodules are the free, mobile, painless, and the extensor surface of the joint. So where the nodules present, they present to the extensor surface of the joints, and the nature of nodules are they firm, and they are mobiles, and they are painless. So this all about the acute rheumatic fevers. We'll come back in new session.